So welcome. Today's Thursday, April 9th. We've got a lot of items to cover on the agenda today. The key program is going to be on telemedicine. I work with a company called K Health, which is applying artificial intelligence to telemedicine, but that's not really the big thing. They're located in New York, and obviously telemedicine is going crazy there. I was going to give you some update on that. Give you some update on our telemedicine programs. We're getting busier and busier in terms of the prevention programs, but not a lot of business on the or activity or uptake on the regular telemedicine. And I think there may be some confusion about that. We'll cover that a little bit. And then Doug Thompson, who's been on this program several times. Doug is a dentist who started the group called Wellness Dentistry Network. I've been after Doug for, a few months to get a teledentistry program set up. And it's not so much, obviously he's not filling teeth. There's a major component of wellness dentistry. It's the oral systemic connection. It's the fact that gum disease is very much linked with heart disease, prediabetes, diabetes. And as you begin to get into the science, it doesn't look like it's just all called gum disease is caused by gum disease is caused by diabetes. It does appear to cause that two-way causality. We'll get into that, some discussions today, and Doug will tell you a little bit about what he's doing now for teledentistry. Then we'll obviously go into questions and answers. Other topics we've covered this week or will be covering. Where have all the heart attacks gone? 40% decrease in heart attacks. And obviously the CDC conspiracy theorists have a heyday with it. They're saying, you know what? We told you the CDC was telling people to say everything is COVID. It's not heart attack. That's not real. I'm sure some of that's going on. But the bigger issue is people are not coming to the hospital with heart attack. On the other hand, a lot of COVID patients are having heart attacks. So you start to put a few things together. And again, I'm not going to recap that whole event. We discussed that yesterday with Janice. Today is going to be telemedicine with Doug. And tomorrow is going to be COVID silver linings with Janice. It's probably going to be next week before we cover the Lancet article. Single sound bite on that one, 37 days of shedding the virus. So we're not going to be over COVID for quite a while. And then an update on the ACE2 receptors, ACE inhibitors, and ARBs. A lot of information. Bottom line on that, I'll go ahead and give that as well, is that huge amount of research going on in that area, but really no change. Continue to take it. I'm continuing to take mine. And actually that whole theory that maybe it even helps taking ACE inhibitors and ARBs, that theory is growing and growing in terms of support. We're going to get back into telemedicine right after this intro from Carl. So we're going to get into telemedicine, but I have to tell you my experience about telegroceries, remote grocery access. We had our first big grocery event, delivery event last night. It wasn't a delivery. We picked it up. We did it with Kroger. We had talked about that as Kroger and the other grocery stores over the past week have started limiting the number of customers that go in the store. I didn't go in there anyway. I haven't been in a grocery store or bought groceries in over a month. Janice got some 3 weeks ago, but she snuck out, mostly got her groceries, and I had said, come on, please, let's plan this. Anyhow, you could tell there was a little bit of debate and back and forth on that. So anyhow, we did get together. We went to Kroger. It used to be Click List. Now it's Kroger Pickup. It was not good. They were over an hour late. There was no explanation. They did give an apology. One person came in, they disappeared, never came back. Multiple cars were going through that came in long after we did. And they said, okay, well, we screwed up. We really didn't pull your stuff. And so we're going to give you $5 off. Well, this was a $240 grocery bill, and we didn't get a third of it. So they should have given us about 80 or 90 bucks back. And so that didn't work very well. The Kroger site, there's another issue in terms of quantity and putting it in the cart. As usual, the systems are just not that good. I called back to basically say, you know what, help me. You're a manager. You're living this. I know it's a hell right now. You're trying to figure out how to, everything's going to delivery. And I know that Kroger, I used to work with Kroger. I know that they have some challenges with systems. Is there anything that you can tell me in terms of hints? Should I come in the morning rather than the night? Should I do smaller? I got somebody who didn't want to answer any of that. He just said, you know what, call back tomorrow morning, talk to a manager, and that manager will go through all of your, we'll do accounting on the list with you, and they will give you money back on stuff you didn't get. And I said, that's not what anyhow, it was clear I was not going to get anything from him. So I did call back this morning, got no answer. As I've mentioned, I've worked with Kroger in the past. And Kroger's done great until the past 20 years ago. They've had great low prices, solid quality, but not the utmost quality. They didn't provide a lot of bulk. Their systems were not that strong. And here's what's happened. Walmart has come in with major decrease in prices, major bulk, and now they're starting to get into delivery. I read a great article this morning by a fellow who does this sort of thing and actually consulted with Kroger. And you could tell at the end of the day, he said, they hired me to come on and do what I suggested that they do in my Forbes article. And they didn't want to do this. They didn't want to do that piece. And you could tell he was trying to be nice, but they got challenges. My solution, I went to Amazon this morning. Hopefully we'll get better results there. Now, so that's an update on that. A couple of other quick comments. Somebody's asked me a couple of times about primary heart disease with COVID. I looked it up last night, and yes, there's a big question around that. Now, how big is that question, and how significant is it right now, and how much answer do we have right now? The bottom line is there does appear to be a significant amount of evidence that COVID can cause damage to the heart, or at least inflammation of the heart, in addition to, or maybe related to, the problems with fluid in the lungs. Now, that injury to the heart does appear to be something that may cause heart failure. Here's the problem. Heart failure causes your lungs to fill up with liquid. Inflammation around your alveoli causes your lungs to fill up with liquid. This is what's killing people with COVID-19. Their lungs are filling up with liquid. So it's going to take some time, in reality, for us to figure out which is the primary and which is the secondary, the inflammation around the alveoli in the lungs or the inflammation of the heart tissue itself. And again, that's about the extent of what we know. Again, there's more research being done on this one bug right now, faster than any other disease I've witnessed. We'll figure that out. Until then, I think the biggest, we don't have testing, so we can't do contact tracing and quarantine. We can't do cluster tracing and quarantine. We just want to make sure we stay out of harm's way and be careful how we shop for groceries. Telemedicine, New York Health, New York Telemedicine and K Health, PrevMed, our general telemedicine offering, and teledentistry with Doug, and then Q&A. So, first of all, let me just say this. On a regular update, we're seeing more and more and more cases. I don't have to tell you that. That's not news to any of you. The U.S. is the epicenter appears to be the epicenter for the world now. New York is now has almost 3 times the cases of number 2, Spain. So again, mass testing and case isolation and control, like you saw in Singapore, Hong Kong, that's not an option for the U.S. at this point. At least early control. So what do we do in the meantime? We stay at home, we social isolate, and as many have said, it's not social isolation. People have answers. We have things like Zoom. Well, Zoom, grew up like a factor of 20, like 10 to 20 times within a week and blew up, and you've got porn bombing and stuff like that. But you've got a lot of other tech options for social isolation or physical isolation. One of them is telemedicine and telehealth. So can using telemedicine flatten the curve? Obviously, a lot of us think so. Harvard Health Publishing, can telehealth flatten the curve of COVID-19? Google's introducing a lot of COVID-19 products. And we're introducing some. We talked about it a couple of times. What's very interesting, though, is we've gotten very little uptake on it. Classic with us, we don't advertise very well. We don't market very well. We don't get our stuff out there. And I think that's our major problem right now. We've got some explanations. We'll be providing more information about it. It's basically a 15-minute non-emergency visit. That's very different from our routine services, which are preventive services between 30 and 90 minutes. This is, again, a quick and easier thing. It's something I've done for, 25 years of my life. Back when I was the chief medical officer for MDLIVE, I managed a staff of about 800 docs. We were the number 2 largest telemedicine provider. Again, not for prevention services, but for just plain old, hey doc, I got a sore throat, I got a cold. Hey doc, I've got allergies, that sort of thing. So again, as you see, we've got some history. Michelle or Carl, as you look at this, probably maybe the most important experience in this space would be the MDLIVE as opposed to Kroger, Hopkins, or Toyota. So that may be something we want to add and change. So again, on a personal basis, I'm really busy, but if you're finding the need to do that, we're certainly making ourselves available. So a quick couple of comments about telemedicine in New York. I shared with you a couple of times, and unless you're a real aficionado of this channel, you probably never heard of it, never saw it, don't remember it. I even tried to find a couple of those videos on my own channel and had a hard time finding them. I was focused mostly on artificial intelligence and medical diagnoses because that's what K-Health does. It's a software program, and it actually applies artificial intelligence to improve the diagnosis for the doctor. That is a big deal. And I'm working with that. I've been working with that company for over a couple of years now. And one of the major roles that I have now is helping them run and chair the credentialing committee. Now, why are improved diagnostics important? Well, if you look at it, studies have been done. Docs tend to miss over half of the diagnoses first time coming around. And you know that 90% of insulin resistance, prediabetes, patients are not even aware. But docs, on the other hand, are very comfortable that they know what's going on and that their diagnosis is correct. Now, I got to skip down to this last comment. What's Gary Kasparov got to do with this? See, this was the thing. It's artificial intelligence applied to, people say, well, you can't apply artificial intelligence to something as complicated as medicine. You're looking at multiple different components of the history. Everything is on an if then kind of logic scenario. And so, for example, if they have cough, do they have fever? Do they have sore throat? If they do, then we go into, if they do have a fever, then you go into more of an infectious process. If they don't have a fever, then you go into more of an allergy type of process. So how can you actually apply AI to medicine? It's the same thing in chess. I mean, Gary Kasparov, the chess master, he got beat a few years ago. The first time out of the blocks, he won. But then the second time, he didn't. And he made the point. He said, artificial intelligence is now smarter than any human chess master is ever going to be. And making a good diagnosis is very, very logically similar to playing chess. So, and if you have any interest in, if you're into Forbes and that group, Forbes actually did an artificial intelligence AI 50, where they had another group come in and vet companies that were actually applying AI, because everybody's wanting to say, we apply AI to home design, we apply AI to a gazillion things, we apply AI to medicine, and K-Health is actually doing it. So they were in that Forbes AI 50. Now, what's the update? Well, gosh, obviously, if you're in the epicenter of COVID-19 for the world, and they've got currently, and they've got field hospitals set up in Central Park, then you can imagine people are wanting to get much more focused on telemedicine, and that is the case. K-Health is growing like mad. We are doing over 30 credentialing processes per week now. And each new credentialed doc is able to see over 30 patients per day. So as you see, massive scaling and growth in that area. Now, the topic for today is, again, as I've worked with Doug Thompson several times, I've said, Doug, you know, in the first couple of years of me doing PrevMed, it was over half of my patients were dentists quite often. And dentists of all of the groups within healthcare tend to say, just don't get their head around teledentistry very well. And I understand it. I mean, they do dentures, they do procedures, they think 3D, and they do procedural work for a living. And procedural work, it doesn't work very well with telehealth. However, Doug's focus has always been oral health and its impact on systemic health, cardiovascular disease, prediabetes, diabetes. And to me, that is almost all an educational focus, very similar to other chronic disease prevention. So I've been bugging Doug for months to get set up with teledentistry. Doug, are you there?
I'm here for it.
Good. I can't see you on the screen share, so I'm going to go ahead and let you take over from here.
Yeah, thanks, Ford. And I think, Ford, you have control of the slides, I believe, correct?
Yeah, just let me know when you're ready to click.
Yeah, you can. You can go ahead, because what the salivary diagnostics is for it is, you, just as you've mentioned, and any of the people that have spent time on your channel know that there's a significant correlation, and there's a significant contribution from your mouth, obviously, to your systemic health. And what you see on the screen are really just two pictures of teeth, except one of the pictures on the left has gum tissue that's healthy. It's not healthy, but it's actually inflamed, but it's gum healthy, that's at the right level on the tooth. And the one on the right is a patient that has very healthy gum tissue, but had a really bad periodontal disease. And what makes—
Can I interrupt just a second, Doug, and just make sure that we got that?
Yeah.
The one on the left, they've got inflammation, but they don't have, but their gums are up at they don't have retraction or loss of gum tissue. And on the right, they've got healthy gum tissue, but they've lost a huge amount of their gums, correct?
Yeah. So one of the things that we would ask our consumer folks is, I mean, they watch gum recession and they can see gum recession. And so if you see gum recession, then there's a reason why that gums are receding, and typically why that's happening is, for a lot of people, why that's happening is there's a certain type of bacteria, yeast or viruses that live in the mouth, and that's making that process happen. What you helped me understand for a long time ago is that not only do those bugs affect the teeth, but they affect the biology of the blood vessel. And your channel's ripe with carotid intima media thickness changes and blood pressure changes and cholesterol changes. And so these bugs in the mouth do all that stuff. So what I was thinking, if you go to the next frame, this was further confirmed to me about studies that now show 57 associative diseases with mouth bacteria, yeast, or viruses. And I thought it would be kind of cool if people could learn what their bacterial load was, because this is exactly what I do as part of the diagnostic process. When I have somebody walk in with gum disease, first thing I want to know is what's living in there. I want to find out, because then we would take a targeted approach to treat that patient for that disease. And you can go ahead forward and advance to the next slide, because I think what it shows.
Well, before we do, if I could make the comment, you start look at, it looks to me like these little barbs on the outside of the circle are prevalence. And sure enough, look at these top 4 items: diabetes, prediabetes, diabetes type 2, and glucose metabolism disorders. Again, core stuff to the folks that watch this channel. You go over and look at things like rheumatoid arthritis and Sjogren's syndrome. Again, those are most people don't recognize and realize it, but those are inflammatory diseases that create as much risk for heart attack and stroke as diabetes in and of itself. And then you've got over here just inflammation per se. Then you've got the renal diseases, different things that are associated with inflammation and cardiovascular disease.
Yeah, and endothelial dysfunction.
Correct.
So what this is a close up of that crevice between the tooth and the gum, and these bacteria live there, and through a simple swish and spit test I'm now offering through the mail, I can find out what the presence of what bacteria are there and the load of what bacteria there are. Now, I want to be clear this doesn't check for all the bacteria in the mouth. This test, what it does is it checks for the main actors that are most implicated in systemic health concerns and in periodontal disease. So that's really what they are. Now, we have, as the salivary diagnostics expands in dentistry, we'll have other things that we can check for. And you can order all kinds of salivary tests through the mail for cortisol and other types of things. But in dentistry, what we're looking at are specifically bacteria, yeast, or viruses. And I have separate tests for each thing. And now we're going to be looking for COVID viruses. And people have COVID, we could determine that through a swish and spit test. So we want to offer that kind of thing as well. So you can go to the next slide.
Before we do, just a couple of comments from my side. Number one, I've used a couple of these before. One of them was oral DNA. I don't know what this one.
That happens to be the oral DNA one.
Okay. The other thing I would share with the viewers today is that I saw somebody who actually is a friend of mine last week, and he broke the record in terms of arterial age. He was, at least in terms of my recent experience, he's 60 years old, so it's a male, and males tend to have higher CIMT values, higher arterial age, and his arterial age was in the mid-40s, and that was despite the fact that he had a significant BMI issue that he knew about. He and I talked. Obviously, he's got some good genes, but he said, you know what, I don't know for sure, but I really discovered this oral health thing about a decade ago, and I have gotten fastidious about making sure I clean out the junk in my gums, between my teeth and my gums. I'm a fastidious flosser. I'm a fastidious what do you call the oral jet, the
Water
wash,
pick, yeah, water pick,
water
hydrofloss.
pick, yeah. And I can tell you from my own experience, that's one of the things that I think made a big difference in terms of my own arterial health, going from 73 at age 56 down to 52 at age 60.
Yeah. Yeah.
Big deal.
And for that study that, or these, you see these advertisements or you see these public health awareness announcements that, if you floss, you can reduce the risk for a heart attack or a stroke. And those are really broad comments and broad statements because they're just telling you to remove the stuff off your teeth. There's no evaluation of whether the stuff on your teeth is harmful or not. And as you were mentioning artificial intelligence, we don't have the ability to determine just by looking what the makeup of the bacteria is, but there's people that have a lot of grunge on their teeth, but it's not harmful. So if you have that, then maybe it's nice to knock the barnacles off your teeth if you want to, but it's not going to cause disease if you just have a lot of plaque. So these general comments, we're trying to get a little more targeted, a little more specific, and then find out who has the bad acting bacteria. And if you have the bad acting bacteria, then you would use some type of tailored strategy to eliminate those bacteria. So we personalize those plans for our patients. That's what we try to do.
To that point, Doug, with the oral DNA and my own, when I dropped like 20 years of arterial age, my original oral DNA looked a lot like the one we see on the screen right now. Significant high-risk pathogen load, the red ones on the left, moderate amount of the moderate risk and low on the low risk pathogens. As I improved, and again, personally got very fastidious about my gum care, the reds just dropped. They plummeted. The moderates stayed about the same. They plummeted a little bit, but the greens increased dramatically.
Mm-hmm. Yeah, and the green bacteria, Ford, we know that bacteria that don't have as much pathogenicity or they're not as infective, if you will, it takes some healthy bacteria have to overgrow or have to grow a lot to set the stage for health to happen. So what was happening in your mouth is you were getting and you were seeing some microbial shifting, right? These bacteria were shifting and you were shifting from having higher risk pathogens that weed out those healthier ones. And then as you get those knocked down, the other ones will come up. And it's nice to test that because it gives you some feedback as to how well you're doing and what's happening. And all the risk, most of the risk in medicine into your systemic health is coming from these red and orange bacteria. Now, Ford, what you see on the screen there, that's a test that looks for 13 bacteria. I mean, I have some tests that look for as many as 29. I mean, we have other types of tests that we can use to that point. And as we're talking about telehealth and artificial intelligence, and kind of what I wanted to say is, the artificial intelligence helps you with thoroughness. I mean, when you're trying to talk to somebody and they ask you some questions and you're on the phone and you're trying to think of the questions to ask, it's kind of like an airline pilot. They have a checklist and they go in and they check every box. And that's what the artificial intelligence does. It reminds us, hey, you forgot to ask about this. And, there's already some chat going on with this particular presentation today about, mouth taping and breathing at night. And I know we'll spend some time at the end answering some of these questions, but there's a lot of cool things that can contribute to the control or the lack of control of these oral bacteria. And that's why we're also trying to include in our home service, we want to have a virtual hygienist because, you got to have health tips. And even though I'm happy to spend some of that time on the phone, I'd like for people to have access to, lifetime access to a virtual hygienist where they could ask these questions and, is the water pick right for me? Or what should I put in the water pick? Or what kind of toothbrush? Or I heard charcoal toothpaste is great. Should I use that? These are all kinds of questions that I don't mind being involved in, but I want to have a forum where they can have that answered, when they want.
That's the same analogy that we have with medicine, with prevention. The key stuff is what a health coach can tell you, and how a health coach can help you get the right health habits it's behavior. And again, you don't need a doctoral level person to teach the problem solving on the behavior. But what you and I need to do at our level is make people aware of the reality of the impact that these things have on people's health.
Yeah, and that's why Janice's work is so important, right? I mean, this whole health, changing behavior. And I have people tell me all the time, and I know you've done this, I have people tell me all the time, well, when she introduced me to this, she or he, we have both hygienists, when they introduced me to this one tool, I mean, everything got better then. And I could never use the floss, but I really love this little pick you got me. And so that's, those are good things. And so that's why we need those people.
That's my favorite tool at this point.
You got it in your pocket.
Oh yeah, I keep them in my pockets. Well, it's interesting, as you know, from working with me, that again, a few years ago, the vast majority of my work was in the dental community. And I have to tell you, as much as I ate out with dentists, I could see their eyes just sort of react because we go out and I'd feel stuff in my teeth and I would pull out one of those picks and start picking. And it's like, that's not good. That's not, and my point is, I know our society doesn't see that as good, but that we're sort of like taking letting our heart and our arteries take a major hit for social politeness. I think we need to change.
And you do need to get that stuff out from between your teeth, especially if you're using a rinse or a paste that night, because you want to make sure that the chicken's not blocking your rinse from getting in and cleaning in between your teeth.
It is the very same thing as shaking hands. Yeah. And that's one of the good things I think about silver linings for COVID for the future. We're hopefully in the Western society going to give up on this habit of thinking we have to shake someone's hand. In other words, transfer our bacteria to them and vice versa. So anyhow, we do a lot of things to quote, be polite and sociable that are not good.
Yeah. One more comment, to go back to that other slide. One more comment about that slide is, you see those concentrations, you talked about, your bacteria bars were pretty high in the red. It's getting pretty clear today that if you have high levels of certain bacteria, you have something going on in the body, but we just have to find it. And so that's the hard part. And that's why if you send me a patient, I get a lot of doctor referrals, and so do some of my dental colleagues that are even on this today. If you get a physician that sends you a patient, you have elevated HSCRP or you have elevated LPPLA2, and some of your channel people know what those words mean. Those are inflammatory biomarkers. We know that reducing the load of those bacteria will have an effect on that. So oftentimes we're one of the last resorts that sees a patient that you're having trouble managing. And I think what you and I are trying to share with the world is we need to manage the cardiovascular health that feeds the heart and the brain and all the other organs, but vascular health. But we also have to manage, there could be a significant player in the mouth, and we want to find that out for people. That's the idea. Yeah. And on the next slide, it basically just reminds us that what makes a big difference about whether you have disease or whether you don't have disease, and I know you've alluded to this a lot, Ford, with your genetic piece, is it's what bacteria are there. So what's the makeup of the biofilm? We call that biofilm, microbial load, bacteria, yeast or viruses, kind of all the same thing. And then how do you live your life? What do you eat? How do you eat? This is why, again, Janice's work. How do you eat? Do you exercise? What's your sleep quality? And we can even digress to the mouth taping question. I think Kurt, you get to it at the end, but I think Kurt asked the mouth taping question, and we are encouraging people now to seal their lips when they sleep because it changes the pathway of the air to go through the nose, and you make nitric oxide in the back of the sinuses, changes your tongue position, gives you more parasympathetic tone. All of these good things happen when you're not breathing through your mouth. So, and we'll get to those. Maybe we'll get to those questions at the end. So what we created is just a home dental exam. It's a landing page on my website. It's pretty rudimentary right now because just what you said in the beginning, we're not used to working on the phone. I mean, I have to see something.
Right.
I need to work in the mouth. And I think the other thing we do is we give away a lot of advice for free. So we take emergency calls on the weekends, and we have done these things in the past, but now we're going to have some changed working rules to how we see patients. And there's going to be some patients that are just simply a little skeptical about maybe coming in, or they don't want to get right back to us, and their health is deteriorating because of their mouth, and we need them to keep up. So what I'm giving people an option to do is to have some testing that could happen through the mail with an interpretation guide, maybe a virtual hygiene visit or two, or a virtual hygiene access. This is kind of the idea. And we're just getting started with this concept because Ford in dentistry, we haven't been so comfortable with it. But we can, we're not going to do fillings over the phone, but we surely can help people and guide people. And with some more comprehensive data, maybe some photos, a medical and dental history filled out, and we call it a risk modifier form, so we can learn a little bit about their life. If we have a few of those things, we can get pretty close to what's going on, and we can determine who needs to be concerned and who doesn't need to be concerned so much. So that's the idea.
So you can't give them a beautiful smile, and you can't give them you can improve their smile, but you certainly can't fill a tooth, but you can save their life. So maybe a pretty good trade-off, huh? Yeah,
that's what we're thinking. And again, this isn't going to be for everybody, but the people that want to know are going to want to know. And the good news is you can do something about it. And just like, when you do a CIMT, some people will say, well, I don't want to know that I'm having a problem until I get, chest pain or I get shortness of breath. But we already know for a lot of people that's going to be too late. So we have a menu of items you can select from, and it's pretty self-explanatory. If you go on and look at it, it's pretty self-explanatory. It's just homedentalexam.com. Pretty simple. And we'd be happy to help. There's a group of dentists that would love to help patients, and we are just going to have to get a little bit more savvy about how we interact with patients and what we do. And I can't, thank you enough for at least exposing this new avenue. And, you talked about your teledentistry not getting a lot of traction right now. I think right now, Ford, people just want to survive. I mean, we're trying to figure out what to do to survive. So our services that we're creating are probably going to get to be a little bit more widely used when people calm down and we start to re-enter a little bit, but we're not really sure how to do it. That's when I'm hoping that we can help people. And if you have you could do, I can see a lot, like these cameras are getting pretty good for it. You get good webcams, and even somebody with, I could send them, there's a game I think where you play, where you try to talk with these cheek retractors in your mouth. Have you seen that game? It's a game. Yeah. It's a fun game. I haven't
seen the game, but I've seen you and I have done that retractor thing.
You could put some plastic expandable cheek retractors in your mouth that, I can mail to you, and I can see a lot just looking inside the mouth. And so it can be pretty telling.
So, Carl, remind me, I think I need to do a stop share. Is that right? There we go.
Yeah.
There we go, Carl. Doug, it's very interesting. I didn't think about this. You and I have talked about it multiple times, but I've got a moving situation on my side too, with a lot of things changing very rapidly. And one of the things that I see when I'm looking at your program is I think about my my webinar series. Just October, November of last year, we started a series because people used to be able to get the inflammation panel by request, by patient request. Then Quest stopped it. So I said, you know what? We could make that available through our physician model, our physician contract with Quest. So what we ended up doing was a very interesting process. We ended up saying, look, you can get inflammation testing, and since we're doing that, we'll also throw in OGTT and even an insulin survey. And basically, people will come in. I think it was like $4.99 and they got the labs, the inflammation panel, and the OGTT and the insulin survey. And then we would join a couple of different, we would have 3 webinars where people would actually, you didn't have to show your results, but a lot of people did. They wanted to show their results, and it was very interesting because when you go to a doctor, you hear what your results are, but you don't know how to put it together with others. And people were just extremely complimentary of it. We started, 15, something like that in the first pilot group. Got great reviews. We did it again, went up to 45, and now it's increasing. We're getting ready to try to figure out how to make that more of a something that's easier to do, and something where you could maybe even see if you could get Medicare or one of the others to pay for some of the labs. So you may want to do that with your teledentistry as well. Consider doing more of a digital webinar type of approach.
Yeah, we do webinars. I have through the Wellness Dentistry Network, and people could look for Wellness Dentistry Network member dentists, but through our network, we do internal webinars for dental teaching. We haven't gotten into teaching the public yet. Before, I like the idea, and I've been part of your event before, and I was really impressed at the quality of the people that come and want the information and how interactive they are, and not only that, but how freaking smart they are. I mean, there's a lot of good education that you've delivered to a lot of really sharp people. So it was a privilege for me to do that, and I'd like to be involved more. So that's a great idea. And we too can order an inflammatory panel, the cardiovascular biomarkers for people. I want to know that in dentistry, because if I have somebody that has really bad gum disease, the first thing I think about is I wonder how this is affecting their vessels. And why I've referred you so many patients is because I know these people have problems in the mouth, but I can't do the CIMT for them, and I can't do other things for them. So I want them to know. And boy, we have really, really changed some lives by putting the two together. And that's why we're here, right? It's kind of cool.
Yep. You recognize that name?
Oh yeah, nice. Yeah, nice. Hi, Chris.
Has worked in Doug's Wellness Dentistry Network, is upstate New York. Great guy, great dentist, very, very dedicated to this.
If you're in Albany, that's your man. Yep. To
saving lives. Chuck Kentfield, what are your thoughts on mouth taping at night? I think you already shared that.
Yeah, I think though, Ford, I need to elaborate just a little bit more. If you have a niece, a nephew, a son or daughter, a grandchild, or some child that's snoring or making sleeping sounds at night, this is the very early indication that there's a breathing issue and that there's some kind of piece that could be important. And Ford, you need food, you need water, but man, you need air. And that's what's happening right now with the lung issue with COVID. But people are suffocating at night without COVID, and there's called sleep apnea and sleep disordered breathing. So, and breathing disordered sleep, however you want to slice it. But we are also can do that virtually. We can help with home sleep testing where it's allowed, and we can send something through the mail. But finding out how you sleep and the quality of your sleep is huge. You could even use a app on your phone, right? SnoreLab app.
Yeah.
Really good idea. But that's where that mouth taping comes from. It comes from the idea of breathing through your nose. And if you can't breathe through your nose, then you have to see an ENT or get your nose, you got to make sure you have airway through your nose. But once you have that through your nose, it's great. And one of our Wellness Dentistry Network experts on that is Steve Acker out of New York and Steve Lamberg out of New York. These are great guys who have spent their lifetimes, their dental lifetimes really having a keen awareness about airway and how to help people. Oh, yeah. You know about that, Ford.
I've got that problem. I've shared it a couple of times. I'm glad you brought it up. Everybody tends to think that it's sort of like diabetes and prediabetes. This is only something for those of us who are involved in that are obese. Well, that's not true. Again, I've got BMI of 20 to 22 for decades. And I had what I thought was early morning awakening, which is more of a neurologic issue, until I found out that I was waking myself up with my breathing. So I've done a couple of things. I really began to find that out when I got the Invisalign. And what happened was the Invisalign pulled my lower arch especially out enough to where I started getting more room for my tongue.
Mm-hmm.
Then I went to another oral device recently, and I basically end up alternating between the two, but that has made a world of difference in my ability to sleep.
Yeah, that's great. I'm happy you did that.
Now, Kevin McCord's got a comment. Kevin's a prevention doc up just south of Cincinnati. Now, listen, look, I'm not sure what you guys are talking about.
Yeah.
Janice's comments to me about the unsavory after effects of eating black beans. Well, just kimchi is an alternative. I've tried kimchi. I'd rather have the black beans with the
black beans in an empty room. Yeah.
Chris Maestro, mouth taping for what purpose? A good question, and I think Doug went into detail on that. Keep closed, reduce cavities, gum disease.
Well, here Chuck brings up another point, and the other point is when you're mouth breathing, it dries out the mouth and it changes the oral ecology, and so those bad bacteria, some of those things that we don't want going on in the mouth, can grow more. So mouth taping can keep the mouth moist, which is a lot healthier because saliva is a natural, it's a natural buffer against bad acting stuff. So you got to have good saliva quality and good saliva quantity to be successful. So,
look
who's Dr. Ecker, actually.
Steve, nice. How are you? Long time no see.
Yeah.
Steve is right up in one of the areas that was a major epicenter.
Staten Island.
Major challenges there.
Yeah. Great guy.
Oh, super duper on airway disease.
Yeah.
Sam Furman. After I came back from going out in public, I'll wash my hands and face. Then I breathe in hot steam to clean mouth, nose, and lungs. Using the steamer, is that a waste of time or is it a good idea? It reminds me of the urban myth right now about, go in and use a sauna. Here's the thing. They're talking about trying, and they quoted the degrees. There's the assumption that you're going to heat kill the COVID virus in your airway. And that's just not, that's not going to happen. If you were able to get that much heat, it would burn your airways to the extent where you'd have much, much bigger problems than this. Now, steam, I saw it looked like an ad or an infomercial or something from Brad and his niece talking about gargling with salt.
Yeah, and that was a 3.5% solution of saline. Which if you go and get the Navage unit, I mean, it's 0.9. So 3.5 is more concentrated, but I did want to this was a great spot. Sam's question. This is a great spot to bring up that saline rinse. And I'd like to hear your thoughts on that. So go ahead.
As I've said, I'm a major fan of Brad's. Everybody knows that. I've learned a lot from Brad. His book is just like 101 level stuff for people to understand this whole cardiovascular prevention and arterial health thing. I just don't think that Navage with 3% saline is going to be the solution that keeps us out of COVID. There may be some improvement, but here's part of the problem. If you think about it, and nobody knows this better than you, Doug, and the folks that you work with, Steve Acker and Chris and others, when you get to the upper airway is mixed with the GI tract. And how are you going? I mean, things like saline Navage make an assumption that you're going to be able to totally clean out one and or the other. And I just don't think that's realistic right now.
Yeah, the gut issue is another topic, but there's no question if you have a dysbiosis or if you have an imbalance in the mouth, you could have an imbalance in the gut too. But I think the idea behind the saline was it's out of that Elvis study out of the UK that looked at the manufacture of hypochlorous acid from chloride.
And there's no question.
Can't hurt, right?
Yeah. There's no question that this virus is wimpy in terms of hypochlorous acid. No question.
And one of the things we rinse with is one of the things we actually promote rinsing with is enhancing, that oral irrigator that you talked about, that water pick.
Right.
We have different recipes for things you can put in there or add to it. Now it'll void your water pick warranty, but it'll save your life. So, it's not a big deal about that. But the one of those things is you can put in grapefruit seed extract, or you can put in some bleach, or dilute bleach, those kind of things. So,
hello, Robert Simpson. Hi, Nick. Hi, guys. Jim Hyde, you said if you take a walk after you eat, it takes the edge off the top of the insulin spike. I eat right after I do HIIT. Will that have the same result? It tends to, yes. One of the simplest, easiest ways to do this it's one of the themes in Jenny Ruhl's book, RUHL, Blood Sugar 101, eat to the glucometer. It also fits to exercise to the glucometer. And yes, I will tell you, I've seen positive impact. And you do. You'll get significant, aggressive, intense exercise with large muscles has been shown to have an insulin-like effect for up to 48 hours. When you think about that, that makes sense because we start to see that, okay, well, plenty of other science has shown that you want to get 3 good exercise sessions per week. Well, 3 per week is, times 48 hours is covering most of the week. Great question. Dr. McCord, so very grateful for this discussion today. Periodontal disease is a significant contributor to inflammatory burden and gut dysbiosis. Treatment significantly reduces risk for cardiovascular disease. Absolutely no question about that.
And we know that science on the biology very well, right? The vascular biology piece.
And, it's interesting. You had ads up 20, 30, 40, 50 years ago that there was an association, but then there was this whole bunny hole about, well, it's association, but is it causality? Well, that article that Brad Namey and David Vigorous did, I think makes a pretty good case. And I really don't think you have to go that far. I think just start doing it and you begin to see on an operation.
Well, we've seen so many changes from metrics forward that we believe, the last 10 years since I've been measuring things more carefully, we see those changes. So we know it's making a difference.
Yep. Here's a great suggestion. Hyde and Nick, you guys can't give answers to 1,000 people calling today. We don't have 1,000. We typically have about 100, but we cover about as many as we can over a 1-hour period. A FAQ site would be great. It would be. Now, Doug, you've got a significant WDN site. You and I have talked about making that more available to the public. It's been available to your WDN dentists.
Right.
Any comments about that?
Yeah, I thought about it. We're working on that process forward because, well, just as I talked about in the beginning of this, it would be good for us to have a more consumer-friendly education piece centered around this topic. In other words, people like your audience that really gets it. So we'll actually Acker's on right now, and
Steve Lambert.
Yeah, Dr. Lamberg's on right now, and so Dr. Master Mateo. Maybe a group of us get together and put something together.
I think it makes sense. Just to let you know, I've been working with Chris to start improving more of the. We've got what? Over 900 videos on YouTube, but they're really, really hard to find, especially as geeky as some of these are. And we've looked to start providing content, actual blog type content on our website. Chris and I Chris uploaded some of the first ones just about a month ago. And FAQ is one of the things that we look for in the future. We've got a list of definitions which are coming out in the in the upcoming book if I can ever finish that darn thing.
Yeah, and the other thing is, we have on the website, we have contact at, homedentalexam.com. I think we have info or contact at, our Wellness Dentistry Network .com. And so we answer the questions. We do answer the questions, but they sometimes we don't answer them. It might take us a day to get back, or, I don't have somebody sitting there answering the questions, but we love the questions, and we answer the questions.
If you look at the videos, usually the videos have a significant number of questions and answers underneath in the comments section.
Mm-hmm.
David Ivers, great information. And there is our friend, another national expert in oral airway stuff. So,
and a good general.
Got a question about what do you mean by a virtual hygiene visit?
Yeah, and again, that would be as I mentioned, with a good webcam and some cheek retractors, you could see a lot with somebody's. You could see their teeth. Now, I can't see the bugs. I could see if there's a lot of debris on the teeth, but I can't see the bacteria. So if I could have a look at the teeth, and if I could have a look at the tongue and the throat, and if I could have a bacteria sample, we could probably do a lot. We could have a lot of nice recommendations for how to go. And then if it's coupled with a physician like you, Ford, that has the detailed health information, you could really enhance somebody's longevity for sure.
Yeah. Doug and I have actually talked about teaming up several times. It's just, there's so many things that each of us is trying to do.
You need more to do, Ford.
What's that?
You need more to do.
That's right. Now I've got to take a break for just a second, like a commercial break. Can you believe this? Somebody discovered this about 2 weeks ago, and they gave us a donation. Isn't that neat? All you have to do is you go down into the comments section and you see this in the upper right-hand corner. Right to the right of the comment icon is a little $sign, and you can give money. Now, as you're laughing at $2.99, I appreciate it. And here's the thing. I've shared with folks many times, and I've shared with you before. I was supporting this activity with my day job, and it was fairly expensive. The last year I had a day job, this activity cost me about $80,000 that year. So we've since I retired, we've focused more, and if you put my full-time activity in there, it costs a lot. The value, the market value is a lot more than that, but we've actually gotten to a break even over the past year or so. If we're going to get this out to 100 million people, we need more money than what I'm going to put in from mine, Janice's retirement. I will put a lot of sweat equity into it, but I'm not going to burn our retirement trying to get a message out there. And it's a message that so many people just don't want to hear. Diabetes is boring. Prediabetes is boring. Heart disease is boring. It's for old people. Bill Clifford, when somebody like you makes that kind of contribution, it's sort of Doug and I, if you've heard the old phrase, seen that old commercial about Maytag Repairman, we're sort of like Maytag Repairman, because the stuff that we talk about is incredibly important, but people don't tend to care about it. When somebody cares enough to find out how to actually make a donation and actually contribute some of your own funds to this educational effort, it makes a big deal. And I have to tell you, Doug, somebody put in, like, a few people have put in like $50 over the past couple of weeks. The first time somebody did that, I just had to stop the Q&A. I sort of broke up that people would actually care that much.
That's great.
So Chuck Kenfield had a question about, would you make a recommendation on how to get started with testing? I think that he must have put that down there before you went into your website.
Yeah, it could have been. And, some dentists are working with this. So check with your dentist, but I'm willing to help. We're willing to help anybody through the mail. And obviously right now we're all closed, so we don't know when we're going to open. I'm sure we'll learn that. I don't know, Ford, do you have a feeling about, I haven't heard you make any comments about your thoughts about when you think our society is going to start to get back to some relevance of normalcy. Sorry, Ford. You can just move on if you want.
Yeah, this is a very, speaking of arcane stuff that nobody have ever heard of. Have you ever heard of the play Waiting for Godot, Godot?
No.
I'm not surprised. I'd never heard of it either until it showed at Hopkins one night, and Janice and I didn't have anything to do, so we went to it. It was the most boring 2.5 to 3 hours I had spent in years. But the playwright was, he meant it that way. He's talking, his whole point was, some of the most important things in life take forever. And there's nothing more important to all of our lives right now as a whole from a public health perspective than getting those darn tests. And we still don't have them. We're waiting for tests.
For sure.
And until we are, social or physical isolation makes a big difference, but it is not going to, it's not going to turn the needle that much until we start getting an ability to track down and find out where transmission's going. Mm-hmm. People say, well, people are getting infected now, and can you talk about herd immunity? You've heard of that concept, right, Doug?
Yes.
With something as infectious as COVID-19, as this coronavirus, each person on average infects 3 other people, and that's within about 2 to 4 days, 2 to 5 days. So just decreasing, just herd immunity, sort of like putting those lead bars into a nuclear reactor. You slow down the reaction. And yes, you do. I mean, it's not insignificant. If you just look at going from a 3, you've heard of the R0, the reproductive index. Mm-hmm. Are you familiar with that? Where one person infects on average 3. It makes a big, big difference. And we did the math on that yesterday. If 1/3 of people are actually already infected, that's a person like a lead bar down in the nuclear reactor, and they're slowing things down. But just do the math real quick. If it's 3, if the R0 is 3, and you're doing 1 every 3 days, in what? 3, you've got, in 3 days, at day 0, you've got 1 infected. At 3 days, you've got 3 infected. Oh my Lord, we've got another.
I don't know what you started, Ford.
That's fantastic. In just a second, I'm going to go find out who this is, because that's incredible. Actually, let me do that right now. George Nakos, $10 super sticker. I can't thank you enough, George. And again, guys, when you guys care that much to get this kind of information out to others, it makes I promise I'm not gonna crack up this time and start crying or anything. So, or have to.
You know what, Ford, though? Here's what I would say. I watched, you and I go back quite a little ways. And I watched, we talked about this when you had an idea and you said, I'm going to do this more and more. And I just got to tell you, I have watched you work tirelessly. Nobody has any idea how much time it takes behind the scenes to put together a 45-minute or a 1-hour informational. It's an immense amount of work. So I applaud you for what you're doing. So I appreciate it. And you can't, you can't thank these people enough that are throwing a few bones your way. I mean, it's really nice.
Well, and again, this is more than a few bones, because I've shared with the group that Carl, for example, is in the Philippines. Mm-hmm. We've got myself, Michelle, and Janice here in the States, but the rest of our folks are in the Philippines. Some really well-trained folks, some extremely smart, extremely hardworking, but on a totally different financial scale. So $50 on our side is one thing, but gosh, you can hire some of these folks. 1,000 per month total for a really well qualified person. We've had people at more of an admin level at 2 and then graduate up to 400 per month. So you're talking about a week's worth of full-time work for some people at $50. So my channel, thank you so much.
Yeah, it's very nice.
Big deal. And again, because of the outsourcing, the offshoring, we're helping improve things there as well. So I think a great way to start getting this message out there.
You have no idea how many hotel programs I've done, and a wait person or a staff person in the hotel that was servicing our banquet at our meeting would come out of the back and say, "Oh my gosh, we learned so much." There were 3 or 4 of us standing around the back listening. So there's no question the message is it trickles down to other people that are helping you.
It just takes time and patience, and again, the commitment that we see is huge. So real quick, back to that herd immunity and the numbers. So if you're typically infecting 3 people every 3 days, day 0 you start with 1, day 3 you end up with 3 people, day 9 you end up with 9 people. Day 6 you end up with 9 people, and day 9 you end up with 27 people. If you do that, and if you have a 33% herd immunity, in other words, a third of the 300 million people in the US, 100 million people, then at that point, your R0's going to go back, that typical R0's going to go back to 2.0. Well, what does 2.0 do in 9 days? It's 1 at day 0, 2 at day 3, 4 at day 6, and 8 at day 9. So you went from massive growth of 27 people in 9 days down to 8 people. That's not insignificant, but that's still growth. The point behind that is that this disease is so infectious. Even at a 33%, even with a third of us getting infected, it's still not going to slow it down to the point where we get an R0 of 0 or an R0, a reproductive index of less than 1, which you need to have in order to control the virus. So this is not going to go away. I did typically, you asked me what time it was, and I told you, and I started talking about how to make a watch, but Todd Foster. Wow, we're getting some attention and focus on this. Thank you so much, Todd. And George and my channel and others.
Nice.
So, Wellness Dentistry Network. Bill Clifford. Yes, if your dentist has an account with one of the salivary diagnostic companies and understands how to interpret, also you can pursue a home dental exam online. So I think Bill Clifford had asked the question, can my dentist do this? And again, it's similar to a lot of the stuff that I do. Yes, your doctor can do a CIMT. Yes, your doctor can do a calcium score. Yes, your doctor can do a OGTT, and your doc can do an insulin response to the OGTT. It's just that they don't. Not very often.
And Ford, I wish the tests were less expensive. But in dentistry, you can get salivary diagnostic tests in medicine for some pretty inexpensive fees. But in dentistry, this is still a little boutique-y. And one of the things that's the problem with it is insurance doesn't cover it. So typically insurance doesn't cover it. So that's why a lot of dentists aren't involved with it. It also takes it takes a significant amount of training to really learn what to do to manage the biofilm once you learn what it is. And so that's really what our WDN member dentists are learning and are about, is how to manage that biofilm load, because that's not easy.
Now, you can't say this, or maybe you could, I don't know. I've heard you use I won't even say I've heard you've used the term, but it's a term that I hear quite often when we're in this space, the drill, fill, and bill dentist, where, it's just like the docs who get up, they go to work, and they see so much of the death and devastation and disability, mostly associated with prediabetes and inflammatory diseases.
Yeah.
They think it's just part of normal aging. So they go on with their work, which in their mind is drill, fill, and bill.
Mm-hmm.
And forget about all this other stuff because it takes time. It's hard work. And
it's the same thing with your colleagues that were doing bypass grafts. Why spend time teaching somebody how to prevent the disease when I can just put that stent in and make a decent amount of money doing that, right? That's the same thing. So we're trying to be. People have asked me, why are you trying to control the biofilm in people's mouths? Isn't that going to put you out of work? Absolutely not. Because you're going to do so much more to keep them healthy. And just like on your channel here, if you can create some ambassadors that understand your approach and appreciate it, you do need to be paid for your educational efforts, and you do need to be paid for that piece, because it takes a lot of time. But it can be really valuable for people. And what don't they get to do? They don't get to have pain. They don't get to have a bad hospital experience or a dental experience. Many people can really reduce their risk, and then they don't need to be in quite as much. I mean, they still need to have regular maintenance, but they're not going to have catastrophic issues, where you go in and it's so expensive.
Good point. And I've got a slightly different point. I'd like nothing more than to put all the doctors and dentists out of business. We can all find work doing something else.
Yeah.
But, that ain't going to happen. Not in our lifetime.
Yeah.
Heiden's got an interesting suggestion. Ford and Doug seem to make a great team. Is there a chance Doug could come on the live stream once a week? I don't think I could take that, Doug.
I don't think Heiden's knows how boring dentists are.
But Doug has been on, what do you think, a dozen times or so?
I don't know.
Been a lot.
Yeah.
But this was a good time to go ahead and reconfigure and re-up on it. And we got some great response today, Doug. I think we ought to do it more.
I will come back. I'll come back anytime for it. A lot of things we could talk about.
Very good. Anything else?
Nope. I think I just would just want to remind people we're here to help, and we would love to be able to do it. And Ford, what I also think is there's probably a lot of physicians out there that wouldn't mind knowing what the salivary content is as it relates to pathogens that affect heart disease and brain health and some of that. And I'd like to help them too. So if we can be a help to anybody, we'd like to be. And and I really thank you for giving me the opportunity to come on and have a little dialogue with you this morning.
One of the things that I think we probably should focus on, again, one of the things that I've done is I've tried to, as you know, this was our typical evaluation was $4,000 just a few years ago.
Yeah.
And compared to 10,000 at California Health Institute and some of the others, you got a lot better information. You got life-saving information. You didn't get the spa effect and the nice music and all of that, and a weekend in Four Seasons hotel,
right.
But you saved your life, which is a much better, it's a big deal. So I've continued to focus on trying to just get at least people started in more of a mass effect rather than just, a few hundred. One of the things that we did, and one of the things that became the casualty of that, was more of the focus on the oral health. We did it education-wise with you.
Yeah.
But we didn't, that's not, the oral health, for example, right now is not part of our core service that we advertise for like $1,000. I think that's one of the things that we should talk about for the future.
Mm-hmm. One additional thought, closing question. Nancy Hartrick, another great dentist friend of mine in Royal Oak, Michigan, asked the question if you could address the nitric oxide piece. And Nancy, I just sent forward 12 different papers about nitric oxide, and we're maybe going to revisit it a little bit differently. Is that a fair statement, Ford?
It is. And this is not the first time I've heard about nitric oxide. The Doug sent me about, a dozen articles. And they're really good articles. There's no question that nitric oxide makes a huge difference in terms of our intima, the endothelium. And once you start getting into the science, you start finding out different parts of the intima that are involved with this. You also look at other supplements. Now, here's where the disconnect, and Doug and I were talking about that some prior to the show today, and that was it's sort of like the CoQ10 issue, ubiquinone. There's some fairly good evidence that ubiquinone may have some advantage over CoQ10, at least from first blush. But after you start digging deeper and deeper, it really becomes very difficult to understand why you need to be paying $40 for ubiquinone, and is it really worth twice what regular CoQ10 is? And you see that with a lot of the nitric oxide supplements that, you know what, plain old simple beet products, beetroot, eating beets, etc. You know, the problem with eating a lot of beets is a lot of beets have a lot of carbs in them, and most of us who have endothelium problems got them from glucose metabolism issues. So, but as Doug was pointing out when we were discussing this, you know, the beetroots products don't tend to have those kind of carbs. It's just there's no question that that a lot of the beet products, a lot of these supplements do help with nitric oxide. The question becomes a little bit more nuanced in terms of, is this specific super duper supplement product that Dr. XYZ is selling and saying is the best thing since sliced bread, is the science for that as opposed to the other run-of-the-mill, inexpensive nitric oxide supplements? Or is that kind of data really that earth-shattering? And I haven't seen any yet that was. So
yeah, and so Ford, I just appreciate you to look at it, but I mean, we're faced with that issue all the time. Is that a company might make a good testing device, like you know, tissue levels of carotenoids. Yeah. I'm always reluctant when a company that makes the machine sells all the supplements, right? That's the little bit of the rub. And you know, we have a saying in our or one of our taglines in our dental practice is everything you need and nothing you don't. Believe me, I don't want to give anybody or sell anybody something that they don't need. The idea is if there is something out there that would help somebody or boost their immune system or help them be more resistant to a virus, surely we'd want them to know about it. So that's the rub.
Yep. Very good.
Okay.
Thank you so much for joining today, Doug, and we'll look forward to doing it again.
Thanks again, Ford, and thanks for all of you that took out the time to listen on. Appreciate it.
Thanks for your interest.
Mm-hmm.